Welcome to the AMSSM online education talk for tonight. Tonight, we're going to talk about the updates from the Amsterdam Consensus Statement on concussions that occurred in October 2022. Very excited to have our speaker tonight. Dr. John Leddy is a professor of clinical orthopedics and rehab sciences at University of Buffalo, Jacobs School of Medicine and Biomedical Sciences. He's also a fellow of the American College of Sports Medicine, American Medical Society for Sports Medicine, and the American College of Physicians. He's done a lot with concussion research. He's the director of outcomes research at the UBMD Department of Orthopedics and Sports Medicine. He also is a Division I team physician and medical director at UAB Concussion Research and Management Center. He was a member of the expert panel for the 5th and 6th International Consensus Conference on Concussions in Sport, of which we're going to talk about the latest one here today. And then in conjunction with Dr. Barry Willer, he developed the Buffalo Concussion Treadmill Test. So he's very well versed on what we're talking about tonight and very excited to have him. I just wanted to remind you that next week's lecture will be on SCAC, clavicle and scapular injuries. We'll have Dr. Allison Lane talking with Dr. Myra Liu moderating, and as always, it'll be Wednesday at 8:30. A little bit of housekeeping things. Our goal for this lecture series is to serve as an adjunct to your program's educational programming and with direct access to you fellows to educational experiences with our more experienced AMSSM members. We may also at times have different formats, but majority of the time it's online lectures. And also sometimes we do some CAQ exam prep. Please mute your device's microphone, turn off your video. There will be questions at the end that you can answer through a Q&A format that you can submit your answers. But if you have questions throughout, just use the chat format and we'll try and get through them as much as we can. And then after the program, please make sure you complete an evaluation. It's usually sent shortly thereafter. So without further ado, we're going to change over to Dr. Leddy, who will give us his talk.
Okay, we'll get started. Thanks. I want to thank Laura for organizing this, inviting me, and the AMSSM with Andy Mayer. So we're going to talk about the Amsterdam updates and the consensus statement and some of the aspects about concussion. I do have some disclosures. They don't affect the content of this talk. If the talk's a little dry, I apologize. It's past my bedtime on the East Coast, so bear with me, please. This was a meeting held in Amsterdam in October 2022, and it was a real honor for me to be there. It was a lot of fun, and it's a great city. If you can ever get over there, I highly recommend it. But just a few caveats before we get into the meat of it. Remember, this statement is based upon the science at the time, and the science evolves. So again, things will change with time, even with respect to this statement. There are 10 systematic reviews that accompany it, as well as a methodology paper. So if you really want to know what all the subjects are about in detail, I recommend them to you. They're very good. It is not a clinical practice directive or a legal standard of care. Remember that, please. It's just a guideline of a general nature consistent with the reasonable practice of a healthcare provider. And individual assessment, treatment, and management of individual cases still rules the day. So this is a little cartoon here, just to remind everybody of what we're talking about here, shaken brain or commotio cerebri. I'll direct your attention to the neck as well in this video. Again, you have to have an acceleration, deceleration of the brain, but you're also moving your neck. So don't forget the neck when you're evaluating concussion patients. So what's the definition? Let's start there. Again, read along with me a little bit here. It's a little dry, but I apologize. This is how we have to deliver it tonight. It's a direct blow to the head, neck, or body with forces transmitted to the brain. This initiates a neurotransmitter and metabolic cascade with axonal injury, blood flow changes, inflammation, etc. Autonomic dysfunction is something else that happens. Typically, the signs and the symptoms present pretty quickly, but they can evolve over minutes to hours, and commonly resolve within days, but as you know, it can be prolonged. Typically, the signs and symptoms of concussion have to evolve within 72 hours or start thinking about another problem. There's no abnormality seen on standard structural neuroimaging studies, but if you look at functional MRI or PET scans, or cerebral blood flow studies, DTI studies, there certainly are metabolic changes after concussion, and that's one thing the field is wrestling with now. What is the importance of those, or what do they mean clinically? Typically in sports, there is not loss of consciousness. That only happens in about 5% of them. And oddly enough, brief loss of consciousness is actually, in my experience, a good clinical predictor of fairly rapid recovery. And this is important at the bottom. The symptoms and signs can't be explained solely, but may occur concomitantly with drug, alcohol, medication use, other injuries, such as to the neck, peripheral vestibular, or other comorbidities, psychological factors, or coexisting medical conditions. And you'll run into this in a lot of your patients, especially in those with persisting symptoms. So, you know the answer to this: find the concussion on a T2 MRI. You can't. There's no bleeding. There's no contusion. It's a functional physiological injury to the brain. Therefore, imaging is generally not useful in your management. So one of the topics in Amsterdam was prevention of sport-related concussion. So I'm just going to hit the highlights here of some of these systematic reviews. So the data show that mouthguard use is supported in child and adolescent ice hockey. That is, mouthguards in those sports have been actually shown to, in prospective studies, reduce the incidence of concussion. So your ice hockey players should be wearing them. Once again, with regard to ice hockey, disallowing body checking should be supportive for all children and most levels of adolescent ice hockey. So there's lots of levels of ice hockey, but those in kids and especially the younger adolescents, reducing or eliminating body checking has been shown to significantly reduce the incidence of concussion in prospective trials. Similarly, in American football, limiting contact in practices appears to also reduce the incidence of concussion for, again, high school kids and younger. So that's another thing that should be incorporated into most American football teams. NMT stands for neuromuscular training warm-up programs. You know, these are like the ACL prevention programs, almost for ACL injuries in soccer. This is based on research in rugby, but it's been shown to work on a limited basis in rugby, that if you're doing these warm-up neuromuscular training programs, maybe you're, you know, sort of improving motor control and having players maybe avoid situations that would have gotten them a concussion had they not done this training. But we need more research in other populations and sports. And again, optimal concussion management, if someone does have a concussion, to reduce recurrent concussion rates is recommended. So what we know is that if you've had one concussion, two concussions, you're more likely to get another, but particularly if they're not managed well. What about the sideline evaluation? So I assume a lot of you guys and gals are on the sideline with your teams. Some things that warrant immediate removal from the field are actual or suspected loss of consciousness, a seizure, tonic posturing, ataxia or poor balance, confusion, obviously, behavioral changes, and amnesia. These are sort of classic signs of a concussion, and if they're observed, the athlete should be taken right off. Now, if sport concussion is suspected, that is, you don't have those classic signs, remove them in the field and do some sort of multimodal assessment using the SCAT tools. Now they are the SCAT and Child SCAT 6s from the latest guidelines. Whether acute concussion is suspected or confirmed, the player should be serially reevaluated in the coming hours and days. That's because, as I said before, the signs and symptoms can evolve over hours to 1 to 3 days. Now, the SCAT tools are good. They are not perfect, obviously, but one thing to remember about them is that they are really only useful within 72 hours of injury. So again, a concussion should evolve within 3 days, and that's when the scat is most discriminant. There's some evidence that for up to 5 to 7 days, they may discriminate, but really it's that first 3 days. And except for the symptom scale, their utility really diminishes. You get ceiling effects and non-specificity. So I would only use it. I don't use it in the office. We'll talk about that in those first 3 days, in the training room or something. And to do a scat effectively takes at least 10 to 15 minutes, probably 15 to 20 minutes with the newer edition. So it takes some time. So what changed from the SCAT 5 on the SCAT 6? Remember, the SCAT 6 is for adolescents who are 13 and above. The child SCAT 6 is for ages 8 to 12. There's a new demographic section. There's a revised recognize and remove and immediate assessment, neurological screen sections. Again, you can look at these. Enhanced red flags in the red here, a GCS less than 15, visible deformity of the skull or enhanced observable signs, falling unprotected, impact seizure, or a high risk mechanism. So someone, gets upended in the air, flips over and lands on their head. You might want to take them off the field and evaluate them. There's some new coordination and oculomotor screens. For example, are the extraocular movements normal? So doing some sort of, again, a brief oculomotor screen is useful. If they are bouncing or regular or producing symptoms, that's probably a concussion. They used to have the athlete read aloud the instructions. That has been removed. And now the memory list is a 10-word list. The 5-word list is gone. Also, there's a timed component to the months in reverse subtest. So that, you ask the athletes to do the months in reverse. If someone's really slow at it compared to their baseline, hopefully, then that should alert you that something may be going on. And now they have optional dual task tandem gait. Again, you have to read up on that a little bit. We'll talk about it a little bit later. If you want to make the coordination thing more challenging, coordination test more challenging. Now, a little bit about using the SCAT tools if you're going to do that. And this is, again, from sort of the literature that if you're going to do this, you should ideally familiarize yourself with the best practices, use of normative data, interpretation of post-injury scores, psychometric test properties, and population base rates. That sounds like a lot. It is. And if you're going to use baseline data, you might want to think about learning about reliable change metrics and base rates of reliable change scores. So show of hands, I do this in live lectures. Who does that or who knows all that? At the ACSM last year, one guy raised his hand in a crowd of about 100 people. Anyway, if you don't quite know all that, at least read the instructions and perform the test correctly. At least we can try to do that. What about baseline testing? Well, again, if you have the finances, personnel, and time to do it, like with professionals, I think it's good to do it. It's probably wise to do it, but evidence does not support across the board compulsory use at other levels of sport. So your high school team may not have the ability to do that, and below that, probably not at all. So baseline testing, I think, is useful, but it's not always available. And for our Canadian friends, skates should not be worn during the MBES test, okay? Now, this is new. It's called the Sport Concussion Office Assessment Tool, the SCOAT. It's an awful name, but that's what we have. This is for the office assessment of concussion. So it's for ages 13 and up for the regular SCOAT, and the child SCOAT is, again, ages 12 or less. And it's basically clinical tests that have demonstrated validity as individual tests have been combined into this multimodal assessment for the office environment, and it has components to be completed in the first assessment in blue, recommended components in green, and optional components in orange. So the again, you can look through the SCOAT 6. These are all freely available at the British Journal of Sports Medicine website, all the systematic reviews and the tools and the statement itself. Now, these SCOAT examinations, again, like the SCAT, don't replace your clinical acumen, but it does provide a standardized framework that can help inform your clinical evaluation in the office. You always want to record how many concussions they've had, how each was managed, and the recovery time. Again, that gives you an idea of their concussion sort of demographics, how many they've had, whether they've had prolonged recovery, etc. And then we always ask about these modifiers, such as migraine headaches, other headache disorders, anxiety, depression. We want to document these because these are risk factors for delayed recovery. And again, like with the SCAT-6, the SCOTE-6 uses a 10-word immediate recall and digit string backwards test, okay? If the athlete finds it too easy, there's a ceiling effect, there's a 15-word list that may be used. Again, that's optional, but it's there. Gratifying to me is that we're including measurements of autonomic function that we can do in the office with taking blood pressure and heart rate, supine rest for 2 minutes, take the measurements, ask them if they have any symptoms, follow this with standing for a minute, measure again, and ask them, do they have any change in their symptoms or symptoms in postural change, lightheadedness, which is presyncope, dizziness, which is sensation of motion. And that should be noted. It could be autonomic dysfunction. The dizziness could also be vestibular dysfunction, or it could be both. Anyway, I think these are important to measure in all our athletes. Don't forget the cervical spine, because most of the concussions you see will have some cervical spine injury as accompanying it. The initial examination should be pretty comprehensive. They say we do the cranial nerves, motor function, sensation, reflexes. It's really to rule out a more serious neurologic injury. This is more important in the emergency room or on the sideline where you don't know, could there be a bleed here? By the time they get to the office, again, that's not going to be typically what you're going to be finding. But develop your own way of doing that, especially looking at the cranial nerves. I'd say that's the most important of all of those there. There's a time tandem gait as a single task that was present in the SCAT-5. There are also these dual tasks that are more complex. They add a cognitive component, such as subtracting serial sevens or the months backward, or recall backwards. Again, these make the tandem gait task more sensitive for identifying balance abnormalities after concussion, and probably are going to be used more and more in the future. David Howell's the guy who developed these. And there's a modified BOMS test, which we'll discuss later. They're all basically all the horizontal components of the BOMS. And then 5 minutes later, you should ask them to recall how many words were in that 10-word immediate recall list. So let's go through them a little bit more on the SCOTE. Again, this is the one that you're going to be using in the office. And at the first assessment, you want to get this history. The symptom checklist is the same as on the SCAT. Now, remember that it's very useful to ask, and in our clinic, we have copied the post-concussion symptom scale for adults and asked them, did you have symptoms before your injury? And then we compare them to after the injury. If you're using the post-concussion symptom inventory in kids, they already have that baked in, so it's very good. But symptoms may be pre-existing, coexisting, or as a result of the reaction to the concussion rather than directly from the concussion itself. And again, this won't be in everybody, but it certainly is common enough. Now, orthostatic intolerance, much like exercise intolerance, we believe is a physiological sign of concussion. And then we published on that. It's associated with a substantial subset of concussion patients. Now, significant changes in heart rate include an increase of at least 30 beats per minute in adults going supine to standing and 40 in adolescents. But remember, they have to be symptomatic for this to mean anything, because there are a lot of adolescents walking around with changes of 40 beats per minute who have no symptoms whatsoever. So again, symptomatic here is key. And what happens most often, everybody, is that they get symptoms without a significant or big change in heart rate or blood pressure. So the heart rate doesn't go up by 30 or 40, it might go up by 5 or 10. And the blood pressure doesn't drop systolic by 20 or 30. It might drop by 5, or might even go up, but they have symptoms, and that's the more important part of this. And they may be autonomic, they may be vestibular, they may be both, but I think this is something we see a lot in concussion, and it's a physiologically based evaluation. Now, this is not postural orthostatic tachycardia syndrome. That happens occasionally in concussion patients, or they get concussions having POTS already. They are very severe on the end of the dysautonomia spectrum. And again, they can barely stand up without passing out. So this is not POTS, but POTS is part of the spectrum of dysautonomias that can happen after concussion. Remember, cervical spine, if it's injured in concussion, it's a risk factor for prolonged post-concussion symptoms. Now, PPCS is defined now in all concussions, kids, adults, and adolescents as beyond 1 month. So it's important that you identify the neck right away and treat it right away. If you do that, you actually eliminate it as a risk factor for prolonged recovery, and that's been published. The BEST test, or the modified BEST, is the most validated tool in sport concussion, but the SCAT5 had a time tandem gait. I like that because it's dynamic balance. The BEST is static. The optional tasks now in the SCOTE from the recent literature include the complex tandem gait, which I use all the time, developed by the group in Children's Hospital in Philadelphia, because it's easy to do and it's got evidence-based number of errors. And I think it's excellent. I use it all the time. The time tool dual task tandem gait, again, adding a cognitive task, as you see below. This is a great work by Dave Howell out in Colorado. And again, this is something that you could consider adding. The complex tandem gait and the time dual task are more sensitive indicators of balance problems because they introduce a challenge more than just a static exam. So I like them both. I've just been using the complex tandem gait because it was first. Ocular motor and visual function. This is very important. This is often abnormal in your younger athletes. Again, the VAMS is validated for ages 9 and above, but the modified VAMS we have now came out last year, where the NCAA CARE data showed that horizontal smooth pursuits, repetitive saccades, and the VOR were just as good as or it gave you just as much information as when you included the vertical components. And then the visual motion sensitivity is also a horizontal component. And again, it narrows down the time, reduces the time of your evaluation, gives you just as much information. I've been using this for years, even before the paper came out. Now, remember, VAMS depends upon symptom exacerbation, and this risks reduced specificity because other conditions can also produce symptoms on VAMS, anxiety, ADHD, and these are pretty common. So again, nothing's perfect, but you have to take this into consideration. Cognitive function, again, we have the word recall, immediate and delayed. That's a member of the SCAT tools. But it should be at least 5 minutes after the immediate recall test, and we're using 10 words now. 15 word is optional. What about computerized neurocognitive tests like these? They may add value if you have them. If you have baselines, they may add value when you repeat them. Remember, the criticism of them is that they have poor retest reliability, which makes their value, in my mind, not as good as your clinical exam, but they are not required. If you have them, it's one piece of the evaluation puzzle, but never make a decision solely based upon their results. Physical exertion. The Buffalo Concussion Treadmill and Bike tests, again, they're validated for looking at exercise intolerance and for using exercise as medicine. Again, if you have the clinical capability, say in a training room or PT office, this can be very useful for exercise treatment for concussion. But if you can't do this, just get them walking, give them a heart rate target. We have papers that show you how to do that without a treadmill test. Just don't cocoon them anymore. We'll talk about that in a minute. A lot of psychological and sleep problems after concussion. Those with persisting symptoms, they have fear, anxiety, depression because they're not getting better. Again, you try to tease out what's from the head injury, what's pre-existing, what's coexisting. These can be sort of complex to figure out sometimes, but there are free screening tools. The SMH-AT1, Dr. Margot Patukian helped develop that. This is specific for athletes. We use the PHQ-9, and there are pediatric versions available. And then there are, you should use a sleep instrument, the Pittsburgh Sleep Quality Index. I use the Insomnia Severity Index. So you want to get an idea about psychological health and sleep because these become operative in those who are not getting better. And Dr. Stan Herring, the great Dr. Stan Herring says, if the symptoms are persisting and intrusive, find out who they are. That is, inquire about their psychological history. The mystery is in the history, he says, and that's certainly true. So there's an expiration date on the SCAT tools. Says 3 days to a week, but I really go by the 3-day rule with the SCAT tools. Now we have the SCOTE. So again, SCAT tools are not a standalone diagnostic. Nothing can substitute for your clinical judgment. Remember, concussed athletes may perform normally, a false negative, just as normal individuals may perform poorly. That's a false positive. It's not a pass-fail tool, but it's very valuable as a structured evaluation of the athlete. It kind of walks you through what you need to do. The same for the SCOTE. Let's move on to rest and exercise. So I think you all should know this by now, but strict rest or cocooning is no longer recommended. There's no evidence that it's beneficial for sport concussion. We talk about relative rest now, which includes activities of daily living. We'll talk about reduced screen time in the first 48 hours. So again, relative rest, reduced screen time is indicated for up to the first 2 days after injury. But you can also even return to light physical activity, such as walking. That does not more than mildly exacerbate symptoms during that initial 24 to 48 hours, but avoid risk of contact, collision, or fall. And if you don't have treadmill testing or bike testing, the individual can systematically advance their exercise intensity based on the degree of symptom exacerbation they had during the prior bout. So if they had no or very minor symptom exacerbation, they can go up in their heart rate. If it produced more than mild symptoms, they should stay at that level or go back to a prior level before advancing. Again, there's a good randomized trial evidence that reduced screen time in the first 48 hours is helpful, but may not be effective beyond that. We only have good evidence in the first 48 hours. Now, those who do have access to treadmill testing or bike testing, this is the best way to prescribe individualized exercise treatment within the first 10 days after concussion. And so we get the heart rate threshold, and we, which is 90% of the heart rate they get where they stop the test at that more than mild symptom exacerbation point. Now, mild means your score on a 0 to 10 scale goes up by more than 2 points compared to your pre-exercise or resting value. That's also for cognitive activity, any activity. So 2 points is okay. Anything but above that, the athlete should be stopping and resting from that activity. And again, you can establish a new heart rate threshold on repeat exercise testing every few days to every week. Depends on the athlete and their rate of recovery. And again, we talked to them about staying below that more than mild symptom exacerbation threshold. We don't want their symptom exacerbation to be prolonged more than an hour. If that's happening, then they're doing too much. They have to back off. And that's what this does. But again, the other important thing that you should think about with your patients is that mild symptom increase at 2 points or less during exercise activity, physical activity, cognitive activity is typically brief, and it does not delay recovery. Now, if it's very prolonged or very severe, it could, but we want them to avoid that. But mild symptoms for a brief period of time may actually be therapeutic, and it does not induce harm. The other thing that early exercise is good for, again, whether you do it with a treadmill or just by, giving them a heart rate to work at and trial and error, it can reduce the incidence of persisting symptoms beyond 1 month. And it's also effective in those in combination with other therapies who already have symptoms beyond 1 month, persisting post-concussive symptoms. But they should be advised not to do things that risk re-injury until they're deemed safe by you or another doctor for doing that. Sleep disturbance in the 10 days after sport concussion has been associated with increased risk of persisting symptoms. And again, I think that's something that should be discussed with the patient in terms of sleep hygiene, things like melatonin. And if it's not helping, then we may move on to other medications and or a sleep study. What about referring? So the Amsterdam conference basically said that persisting symptoms is more than 4 weeks across all age groups, and that you should use something like the SCOTE tools and other clinical evaluations for, say, specific symptoms. Maybe the headaches are migraine-like. Maybe the dizziness is from peripheral vestibular dysfunction, but this can help you to guide your referrals. And remember that healthy people report these symptoms. So you have to, you know, be careful that you're not dealing with sort of a other biopsychosocial factor aside from concussion. Again, this is typically in patients who have persisting symptoms, right? And common considerations are mental health issues, learning or attention difficulties, visual, oculomotor, cervical, and vestibular problems that are not getting better in the first couple of weeks, headache disorders and migraines, sleep disturbance. Again, if they're not sleeping, they're not going to recover. Persistent dysautonomia, again, real exercise intolerance or real orthostatic intolerance, including POTS, and kind of chronic pain. Now, what about rehabilitation? This is not exercise treatment, but this is people who have dizziness and balance problems and neck pain or headaches that appear to be coming from the neck. If this is going on for more than 10 days or 2 weeks now, we're getting them into cervical and vestibular rehabilitation, and there's evidence to support that now. If symptoms go beyond 4 weeks, then active rehabilitation, exercise, and collaborative care, which is cognitive behavioral therapy, especially if they have a lot of psychological and cognitive symptoms, may be of benefit there. You should always be doing some sort of low-level aerobic exercise in combination with other treatments. And again, we'll talk about return to learn and sport, but if the symptoms occur during those staged return to life strategies, then you want to reevaluate them, and they may need some sort of rehabilitation to facilitate recovery. Now, how do we determine clinical recovery? This is pretty challenging, but the group thought that future research or your determination should include 3 things. So again, symptoms, they're important. They're not the only thing, but they are very important. And you want concussion-related symptoms to resolve at rest with cognitive activities and following physical exertion. And so if all those 3 are met, then that's a pretty good indicator that someone's recovered. But, again, other outcomes that are relevant to ongoing symptoms or a specific question, like the response to physical exertion. So in our case, we may do a treadmill test and make them prove they have good exercise tolerance before we declare them recovered. What do you do with post-traumatic headaches, balance problems, VOR, and ocular motor dysfunction, symptom reproduction on VOMs, etc., problems with cognition? Or again, you want all those functional systems to return to normal before you declare somebody recovered. And have they progressed through and completed return to learn and return to sport strategies successfully? That's how we can define recovery. What about biomarkers? You may get questions about this. And basically, if you look at biomarkers, whether blood, saliva, or imaging, there clearly is a window of physiological change or abnormalities that appears to extend beyond clinical recovery. So again, resolution of clinical signs and symptoms is recovery. What this means, though, is not known yet. Are they pathological, adaptive, benign processes, right? We just don't have enough data to link these changes to clinical recovery yet. So again, maybe in 4 years, 5 years, when the next consensus statement meeting is happening, we'll have more information then. So they're not ready for prime time. What about return to learn? I'll just put a little pearl here. If you continue to play in a sport or practice after you've had a concussion, concussion symptoms will last longer. If you don't see a healthcare provider who knows how to evaluate concussion within a week, you also have a longer recovery. So continuing to play and delayed access will prolong recovery in some people. What the Amsterdam conference said was that return to learn and return to sport strategies really can be implemented regardless of age or sex, with minimal differences in the time for recovery. So again, whether you're a child, an adult, or adolescent, male or female, these strategies are for everybody now. Here's the return to learn strategy. And again, you can read this in the document. I'm not going to go through it in detail, but as you can see, it's a gradual increase in mental activities that, once again, don't result in more than mild exacerbation of symptoms, using the same 2-point rule I talked about with physical activity. So that's key. This is also now incorporated into cognitive activity. And again, what this means is that the student does not have to be symptom-free to go back to school. The student can go back to school with these parameters and academic supports in place. So again, academic supports are sort of in the middle there, activity at each step. And you can see there's some information at the bottom talking about how you institute this stuff and what mild means, et cetera, on the 0 to 10 scale. So this is the new return to learn strategy. The return to sports strategy is different now. If you remember from the Berlin statement, there were the first stage was symptom limited activity. The second stage was just light aerobic exercise. Now we've broken this down into 2 parts, 2A and 2B, and this involves different heart rate targets to exercise at. And again, you can do this as long as you want, provided you are staying below the 2-point rule in terms of symptom exacerbation. 0, 1, or 2 points from your pre-activity baseline is okay. You can continue going for an hour if you want. Once you get above that, we tell the athlete to stop and take a break. And I think of these, and then once they're doing that, okay, so only mild symptoms, but doing pretty well, they can start individual sport-specific exercise. And I think of these first 3 stages now as therapeutic. So stages 1, 2, and 3 are really therapeutic now to help speed recovery from concussion in a controlled way. Remember, individual sport-specific exercises like dribbling or a soccer ball or basketball, changing direction, is outside of the team environment, so there's no risk of head injury. If there's any risk of head injury, the individual should be cleared at stage 3 or the end of stage 2 to participate in that.
John, can I interrupt for a second?
Sure.
There was a question that came through, and I think it's timely here. When you say a 2-point increase, is that on a 0 to 6 scale, or is that on the 0 to 10 scale?
That's 0 to 10. Again, 0 to 6 is the scale used in the SCAT post-concussion symptom scale. But this 0 to 10 is really more like a visual analog scale, where the patient is, or the athlete is saying, this is how I feel right now. You know, I have a headache and I'm dizzy, but in my overall sense of feeling on 0 to 10, 0, no symptoms, 10, I feel horrible, is a 4, let's say. And right now in the exam room, I ask the patients, because I want to illustrate this, how do you feel right now on that scale? And if they tell me I feel like a 5, I say, well, you can go out later on and start stationary cycling, and as long as your symptoms don't go up above 7, you can keep doing it. And so that's the idea. It's 0 to 10, not 0 to 6.
Thank you.
So these first 3 stages are really therapeutic stages now, to try to get people ready for steps 4 to 6. Now, at the end of stage 3, the athlete should have no symptoms anymore with activity. They should be really doing all this stuff symptom-free by this point. This may take 3 days, this may take 3 weeks. It's going to be individual, but most stages are expected to be at least 24 hours in duration, but could be longer. So the first 3 stages are therapeutic stages using symptom-limited activity, then light and moderate aerobic exercise. Again, mild exacerbation of symptoms in these stages is okay. More than mild, you go back to your prior level. And then stage 3, again, individual sport drills. Again, you can have mild symptoms again until you have no symptoms with exertion, but you don't want to be doing anything where you risk head impact. And then stages 4, 5, and 6 are non-contact, full contact, and return to sport. So remember, stages 1 to 3 are therapeutic. Stages 4 to 6 reintroduce contact risk. If anyone has symptoms in stages 4 to 6, they're supposed to go back to the prior stage. They're not supposed to advance. They're supposed to go back. And if they can't get past one of these stages, they should be seeing you back, excuse me, in the office or the training room. So again, step 1 can start within 24 hours. Each subsequent step typically takes a minimum of 24 hours. If you're doing mild and moderate exercise, that's probably going to take at least 2 days. And like I just said, you can move into the later stages, 4 to 6, and step 3, if there's any risk of head impact, following authorization by the healthcare provider, and after resolution of any new symptoms, abnormalities in cognitive function, balance problems, etc. Their oculomotor system has to be back to normal. Their physical examination essentially has to be back to normal. And then they can, and they're doing aerobic exercise without symptoms, individual drills without symptoms, then they can move into steps 4 to 6. Okay, and like I said before, more than mild symptoms occurs during steps 1 to 3. They can stop and attempt to exercise the next day. If there's no more than mild symptoms, they can go to the next stage. Again, mild's okay. More than mild, you stop and try again the next day. If that occurs, or really any symptoms during steps 4 to 6, the athlete should return to the prior step. And again, local laws may determine at what stage you have to give clearance for unrestricted return to sport. You can typically expect a minimum of a week to complete the full strategy, and typical unrestricted return to sport can take up to 1 month now. So 1 month is the time frame for normal recovery in all age groups now. But again, if they're having trouble getting through the return to sport strategy, or their symptoms and signs are not progressively recovering beyond the first 2 to 4 weeks, and again, 2 weeks is what I'm using now, think about specific rehabilitation, cervical, vestibular, perhaps vision, perhaps psychological or cognitive, but you're going to need a multidisciplinary team probably at that point of physical therapists, again, speech therapists, etc. And one more thing, athletes should be fully back to school without academic supports before they're returning to unrestricted sport. So they have to be functioning in school like they were before they can go back to play football. So winding down here, the other thing that we touched on in the statement was long-term effects. So I'm going to just summarize the data here. When you look at male amateur athletes, former male amateur athletes, there's no evidence that they are at risk for greater cognitive impairment, neurological disorders, or neurodegenerative diseases versus the general population. So amateur athletes, the data are not there for a neurodegenerative disease. However, and we'll talk about this, former professional American football players and soccer players don't appear to be a greater risk for depression or suicidality during early adulthood or as older adults, but they do have greater mortality rates from neurological diseases like ALS and dementia. Okay, so this is the group that has been exposed to huge volumes of repetitive head impacts over their lifetimes. And generally, it's thought that you have to play these sports as a professional for at least 5 years before you enter this risk pool for a neurological disease or dementia. Now, the studies are flawed because they don't examine or adjust for many factors that affect neurological functioning. These include genetic factors, what education you got to, and that has to do with your brain reserve, your cognitive reserve, socioeconomic factors, smoking, hypertension, cardiovascular disease, diabetes, sleep apnea, white matter hyperintensities on DTI or structural MRI, social isolation, diet, physical activity or lack thereof, or exercise. So all these other factors are typically not examined for in these studies of neurodegenerative diseases in retired athletes. Sorry, Millie. Oh, here we go. Now, what about CTE? So you have to distinguish between the post-mortem neuropathology, which is now called CTE-NC, CTE neuropathic change. Again, that's the hyperphosphorylated tau identified in the brain of deceased athletes. And it is reasonable to consider, as I said, extensive exposure to RHI repetitive hit impacts, like in professional athletes with 5 or more years of professional play, as potentially associated with this neuropathology. This is not a clinical diagnosis. The first consensus criteria for traumatic encephalopathy syndrome, TES, were published in 2021, and moving forward, these will determine to the extent to which the neuropathology identified after death was associated with this new clinical diagnosis during life. The prevalence of both of these, the neuropathological entity and the clinical diagnosis in former athletes, military veterans, and the general population is not known. The prevalence is not known. Remember that. It's also not known whether the neuropathology causes specific neurological or psychiatric problems, the extent to which it can be clearly identified in the presence of Alzheimer's disease, or whether it is inevitably progressive. So again, CTE is an issue. You're going to hear about it. You may hear about it from patients, parents in the exam room. I tell high school kids, unless my math is wrong, you haven't been playing professional football for 5 years, therefore you're not at risk for this. We want to manage your concussions as best as we can, but don't worry about CTE. So finally, whether it's on the sideline or in the office, again, the great Dr. Stan Herring, return to sport ultimately remains a clinical decision made by a qualified healthcare provider. That's what I hope all of you are becoming in terms of sports medicine and concussion care. So I'll end it there. Let me stop sharing my screen. I know it was a little dry, but I hope you learned a little bit about the Amsterdam conference.
Thank you so much. That was a great overview. And we did have some questions that came in. I had some questions as well, but I actually had a question about the mouth guards, and so did someone else. So in terms of mouth guards, we talk about it in youth sports. What about in other age groups? Has there been any evidence to show that wearing mouth guards decreases it in adult hockey, adult football, etc.?
No, not to my knowledge, not as of, when we did the systematic reviews. The only evidence really is in youth ice hockey. And just another pearl, it doesn't have to be one of those expensive custom ones. In fact, the off-the-shelf ones perform better than the, custom ones you get at a dentist. So, this is an easy thing to do for people. They can go get one for, I don't know if it's $10 or something. And they don't have to go to a dentist and have a fancy one made. The off-the-shelf ones are just as good or maybe even better.
Okay. Also the neuromuscular rehab. So is there a paper that was referenced or anything for that neuromuscular therapy prior to that we could share with the group? And that was one question.
Yeah, that's in the systematic review. It's from New Zealand, Australia rugby. I forget the author, but I can get that to you, Laura, if you wanted to.
So do you think, is this something that you talk to anyone about? Is this something that we clinically can use to say, hey, like these neuromuscular therapy programs can be beneficial? Or do you think this is more sort of esoteric, for us to think about?
Well, sports docs, we try to get female soccer teams to implement this kind of thing, and they can do it. So, I think that the group was a little circumspect about recommending for everyone because there's just not the data in other sports yet. But it seems in that one study to have worked in rugby. So, those neuromuscular training programs are probably good for a variety of things. You're protecting your ACL among them, and maybe your Achilles. So, I think we need more. We need more data. I think it'll come out, and I suspect they're probably going to be shown to be okay in other sports. But I think there are several good reasons to do those things. If your coach is invested in it, and you want to be the best evidence-based coach trying to prevent ACL tears and concussions, get them in a neuromuscular training program. And it's not, those programs aren't too hard to implement. You just have to want to do it.
That's actually one of the things I really like for most of what we see in sports is I talk to people a lot about how balance, proprioception, how your brain and your muscles work together can help reduce injury, whether it's ACL, ankle sprain,
Right.
patellofemoral pain, whatever it is. It's that reaction to situations. Because if I'm not mistaken, concussion a lot of times happens when you don't know something's happening. So you get hit and it's that unexpected hit and you're not, you don't maybe react the right way. So I see how that would play a huge part. And I think it's interesting that we could probably pull that in other ways.
Yeah.
I, like you, don't really use the scat in the office that often because I feel like it, most of the time I'm seeing patients, it's not 72 hours, it's usually 3, 4, 5 days. A question came in and said, finance and time aside, is the scat meant to be utilized as a baseline test? Like timed errors don't denoted, and then repeated post-concussion the first 72 hours. I.e., are you using the scat baseline and after? And I think you had said it doesn't seem like it's necessary, but
Well, they have some recommendations for normative data for some of these time tests, but the scat is best, I think, if you do have a baseline. My point is that not everybody has the ability to do that. I think with the scat, it is useful to have a baseline whenever you can get it. With the computerized tests, I don't think so, because I just seen too many kids who don't take them seriously, and their baselines, I think, are garbage most of the time. So, but in terms of scat, I think it is better to have a baseline than not. But we acknowledge that not everybody can do that. So you do the best you can. But if you have the ability to baseline your athletes with scat, I think that is worthwhile.
so I know we do that in our college level, but I think in high school it's a little harder to execute.
Yeah.
Um,
Again, you don't have to, but it's ideal if you can.
2 questions that have to do with return to play. One is, in these stages of return to play, we talk about like a 2A and a 2B. Are those 2 separate days? So we're really making that almost like a day 2 and a day 3, or how are you referring to them as?
Yeah. I think in most instances it will be 2 days, but you could do both in one day if, for example, you had very minimal or no symptoms at 55% of your heart rate. You could then, go on to try and, wait a few minutes or an hour or whatever, and try it at 70% and see how you do. I think most trainers are having them do the first step, which is 55% for one day, and then seeing how they do and trying that at 70% the next day. If they do well with that, then they're going right into stage 3, which is, the individual sport specific drills. And again, mild symptoms are okay. They don't have to be symptom free to go through those stages. If they're getting more than mild, then they should go back to the prior intensity. And so again, there are some athletes who will get through that in one day. College athletes can do that, professionals. I think high school, it's going to take probably a couple or 3, and it depends on, when you see them, obviously, and whether the symptoms are going up mildly or not. So it introduces a little bit of variability into the return to play. I guess it's not as easy as 1, 2, 3, 4, 5. But again, this is best done early on, and we know that the more exercise you do early on in that first week, that's not more than mildly increasing your symptoms, the faster, our data show, the faster you recover. So it's therapeutic.
So I find that, especially in our high school age athletes, that it's really important that we need to educate our athletic trainers of this fact. Like, I had a patient today that came in and said, well, I've not been allowed to do anything for a week because I have a concussion. And we need to keep educating our athletic trainers. So as fellows and, sports medicine physicians, I think it's really important to interact with your athletic trainers and let them know your thoughts and what we're following, and keep them up to date. We're all trying to keep up to date on everything, but I do think that is a super important aspect of concussion care, is making sure, sub-threshold exercise, I think is the term. But how do you feel, or how do you respond to coaches, trainers, athletes trying to pressure you to return a day sooner instead of the full 7-day or 6-day return. What kind of response or advice do you give when someone's trying to say, well, I feel great, can we hurry this on? My game's a day earlier than your return to play.
Well, I feel great. I don't want to sound too cynical, but I don't really believe that until I do a physical exam, and that's all normal as far as I can tell. And in someone like that, I think, who was really pushing me to get back early, maybe they have a championship game on the weekend, and it's really tight. But I think he says his symptoms are okay. That's confirmed by mom or dad. I always try to get confirmation from the parent, because if they say no, he's minimizing, then it's all, I won't let him do it, obviously. But in that situation, if you have the ability to do a treadmill test or a bike and make them prove that they have the ability to go up to near max without really any symptom exacerbation, you could then be confident. I've done this, starting them at stage 3. And that can speed your recovery. Now, before the pandemic, we wanted to do that trial. We were set up to do a randomized trial in high school kids of the regular return to play program versus doing a treadmill test and starting them at stage 3, and see if we could show that it sped recovery safely. And we just haven't gotten back to it, but that's an idea for people. I think that's a study that could be relatively easily done, and it would give us some good information. But again, these are guidelines, and sometimes I go out the guidelines a little bit, but I want to make sure that I have confirmation that this person appears to be recovered symptom-wise and energy-wise, sleeping-wise, school-wise. My physical exams completely normal. They want to push it. I'll say, okay, get on a treadmill and prove to us that you can exercise to maximum. You look at doing it, and we're not seeing you get symptoms. Then I'll start them at stage 3, and that can speed their return to play. And I've never had a problem in terms of that coming back to haunt me.
Good. All right. Well, I know you prepared some questions and you gave us some great information. So let's close this out with a few questions and go from there. Go ahead, Andy, if you can pull those up.
Dr. Leddy, actually, are you able to reshare your screen and just cut to that last slide?
Oh, yeah. Hold on. Oh, sorry. Here we go. Do you want me to read them, or are you going to?
If you could read them out, I'll launch the poll now.
Oh, okay. Evidence-based interventions for sport-related concussion prevention include all the following except mouth guards for children and adolescent ice hockey, policy disallowing body checking for all children and most levels of adolescent ice hockey, limiting contact practice in American football. NMT warm-up programs have been shown to prevent concussion in most sports.
We'll leave it open for maybe another 20 seconds. And then Dr. Leddy, if you just want to talk through the correct answer.
Okay, the answer is D. So again, as we talked about before, NMT training has been shown to prevent concussions in rugby, but not most sports. The other 3 are evidence-based preventive techniques for concussion. All of the following are true for the SCAT instruments except Signs that warrant immediate removal from the field include actual or suspected loss of consciousness, seizure, tonic posturing, ataxia, poor balance, confusion, behavioral change, and amnesia. SCAT tools are most effective in discriminating between concussed and non-concussed athletes within 10 to 14 days post-injury, except for the symptom scale. The SCAT's tools to evaluate a potential concussion require at least 10 to 15 minutes to complete. The SCAT-6 assessment of immediate memory is now a 10-word list. So all are true except for one of those.
Give it another 10 seconds.
Okay, that's good. The answer is B. Again, the SCAT is good really in that first 72 hours. Now, beyond that, we are recommending that the SCOT be used for certainly beyond a week, and in my practice beyond 72 hours. With respect to rest and exercise after sport concussion, the following are true except relative, not strict rest, which includes ADLs and reduced screen time, is indicated immediately and for up to the first 2 days after injury. B, the best data show that reduced screen use in the first 48 hours after injury is not effective for facilitating recovery, but it is effective beyond that. C, mild symptom exacerbation during physical or cognitive activity is defined as no more than an increase of 2 points on a 0 to 10 scale when compared with the pre-activity value. D, mild symptom exacerbation during physical activity, prescribed aerobic exercise treatment, or during cognitive activity is typically brief, less than an hour, and does not delay recovery. So all are true except.
Give this another 15 seconds or so.
Ready? Oh, here we go. Okay, yeah, the answer is B. So remember, it is effective in the first 48 hours, but no data that it is effective beyond that. So again, if the caveat here is that you have to see them right away, or in that first 24 hours for this to be effective. But if you're in a training room or an emergency room or an urgent care center, or maybe you're seeing them right away, then I think it's worthwhile to ask them to reduce, not eliminate, but reduce their screen time. Number 4, which of the following statements are not true? Persisting symptoms after concussion is defined as symptoms for more than 4 weeks across all age groups. B, former male amateur athletes are not at greater risk for cognitive impairment, neurological disorders, or neurodegenerative diseases when compared with the general population. C, athletes should be fully back to school without academic supports before unrestricted return to sport. D, if more than mild symptom exacerbation occurs during steps 4 to 6 of the AMSSSM return to sport strategy, the athlete should try to exercise again later that day. So again, which is not true?
Another 10 seconds on this one.
Okay. Yep, the answer is D. Again, if they're more than, if what they're doing during steps 4 to 6 really is aggravating their symptoms, they are supposed to go back to the prior step and try again. And sometimes they have to do that more than once. If they just can't get past that, then they have to be reevaluated, and you have to think about what's the symptom generator.
Well, thank you so much for your time tonight, Dr. Leddy. That was a great overview. I think that we all got a lot out of that, and good luck with moving forward, everyone. And we'll see you next week.
Nice to see my friends and colleagues. Thanks
Yes.
everybody for your attention. It was fun.
Bye.
Thanks, Laura. Thanks, Andy. Bye-bye.
Bye.